I'm Meshal Malik and you're watching Indus Special. Is COVID-19 mutating? Is the virus acting differently in different regions because there are variants of the original form that began first spreading in Wuhan, China? These are some of the questions regarding the nature of the virus that has now over 20 million cases worldwide. These questions would help us understand the ground realities better. Joining us to talk about it and help understand what's happening is Dr. Munir, who's a virologist with Lancaster University. He joins us from Lancaster. Also joining us today is Dr. Fawad Muhammad, who is the World Academy of Sciences Research Fellow in Virology at the Chinese Academy of Sciences and Fudan University of Shanghai, China. He joins us from Peshawar. Thank you both for joining us and welcome to the show. Dr. Munir, I'd like to begin with the basics just so we can build up from then onwards and try to understand what's happening, because this is very technical, especially when it comes to mutations and how the virus reacts. Now, when we talk about mutations, is that a bad thing? Is that a good thing? Is there one way it mutates? Break it down for us. What really does mutation mean?
So like any other living organisms or the biomaterial, most of the viruses and bacteria and other pathogens, they have a genetic material. And that genetic material is composed of different nucleotides. And those nucleotides are building block for the body. So as the viruses multiply, they replicate into the body. These spellings, which are A, T, G, C, these are coding for the genetic material, change over the time. And this is a part of the whole process of virus replication. Some of those mutations occasionally turn to be very deleterious for the virus, and virus dry out. But in the majority of the cases, viruses use those mutations to get benefit for example, enhanced transmission, difficult to control the pandemics or the infections, or maybe some point vaccine efficacy could be reduced, or may require more vaccine approaches or different vaccine approaches to really get resistance and immunity against those viruses. So as we are seeing with the coronaviruses, certainly there are mutations going on which are raising some concerns whether those are enhancing its transmission or not. But that is something that really need to be watched very closely.
Right. Now, when we talk about the coronavirus, it seems it's often given a life of its own. And as you mentioned here, that the virus often mutates to strengthen itself. You're saying that we need to watch this situation closely, but what do we know so far? Does it seem like it's going in the direction of becoming smarter than the humans trying to fight it off by adjusting itself and becoming stronger, more difficult to fight off?
Precisely. So if we really look on to the very first isolate, the very first virus that was isolated in Wuhan, we had a complete genome sequence of this one in the mid of January. And basically within 2 weeks from Seattle, the next complete genome sequence became available. And afterward, there has been a massive information generated. So far, we have around 50,000 viruses being sequenced all around the world. So this is a significant amount of information for us as a virologist to really look into and identify some of those mutations. Those could have some importance. Based on these sequences, 50,000, all coronaviruses, the SARS-2, which causing COVID-19 nowadays, can be divided into 7 different clades. And hundreds of mutations have been identified. Out of those, 20 of those mutations.
Dr. Munir, I'm gonna interject because you're bringing up a point which creates a lot of confusion, especially for a person who isn't aware of the technicalities of this. A strain, as you mentioned, 7 different, and then a mutation, which you mentioned are hundreds of them. What is the distinction between the two?
When we say strain, basically we mean that it's a one virus. So, for example, if one virus is isolated from Pakistan, another one from the UK, we say that there are 2 different isolates. And when we sequence them, we can identify whether those are different from each other or not. And if they are different from each other, there are certain signature within that. Those are we call mutations. When we would say mutation, mean one nucleotide, which is a genetic code, can change into another nucleotide, and that turn into a protein translation. So ultimately, it's a protein that performs the function. So these mutations are critical for us to also identify where these viruses have come from. For example, if we look onto these mutations in Wuhan, those are now different than what we have seen in Europe. And those are in United States, those are different than what we have seen in Europe. So all of the United States isolates SARS-2 coronaviruses, those are emerging from basically Europe, because we can identify those mutations. Those are taken over from one continent to another continent.
Right. You mentioning something here which will be very, very important for our discussion ahead, which is how different regions have different natures of this virus, different strains. We're going to dig deeper into that, but I want to talk to Dr. Fawad Muhammad and specifically focus on the situation we've been seeing in South Asia. Now, South Asia has been a case of a lot of wonder, has been a case of a lot of intrigue, because for a very long time, while the world was suffering, while the world was seeing a spike in cases, this region didn't seem to be that much impacted. And once it was, we saw Pakistan, which stands out like a mystery case, seeing cases decline very quickly, almost astonishingly so. When we talk about this, what can we say about the nature of virus existing within this region?
First, I would say this virus is a totally peculiar virus. So we have very limited information about this virus. Specifically, if I talk about the South Asia, so we also have very limited viruses that has been sequenced and the data has been available. In case of Pakistan, so there very limited virus has been sequenced, which is very negligible. And alongside, there are other certain factors involved in the virus, in the fatality caused by the virus. Some environmental factors, also the virus fitness with the host, and the virus mutation itself. So in South Asia, this virus is also behave different from the rest of other viruses. But again, I have to say, very limited data is available. As of today, more than 48,000 virus has been sequenced, but very limited in number from South Asia has been sequenced.
And that seems to be a part of the problem, when that there's very limited data, because we see this region as being the most populous in the world. And we're seeing trends that are unique to this region. What is hindering the accumulation and collection of data at this point?
I think we need to go for more detail to study this virus, and then we need to compare it with the rest of the viruses sequenced in the different region of the world, and to see whether there is more mutation or there is less mutation, because the mutation is a kind of beneficial for the virus itself, and it can be sometimes beneficial for the host as well. Like in the early time, when the virus was emerged in Wuhan, so it was divided into two clades, the L and the S clades, but the L was become dominant, and in the later time we have more than 70% of the L clades. But in the recent classification, we have three other clades like the G, which has been more linked to the spike proteins, and we have the V clades, which is more linked to the ORF3A, and clades S, which is linked to the ORF8. So the virus is also mutating itself. So initially, the virus behavior was very aggressive, but what we are observing now, the virus behavior is now more get more fitness to the host.
Right, yeah, it's changing in that sense. Fawad Muhammad, stay with me. I'm going to jump back to Dr. Muhammad Munir and talk to him about this. Dr. Munir, there's a lot of anecdotal evidence that is coming out of Pakistan. A lot of doctors continuously say this as they see more patients coming in with milder symptoms, saying that the virus has mutated, it has become more weak. What's happening in Pakistan? Is this something that can also be compared to any other part? Is there a precedent for what's happening? Or because this case seems to be really unique?
Yes, absolutely. I've been watching Pakistan situation very closely, not just being my motherland, but also to really look into the current scenario. We have several viruses, those already been sequenced, and based on that, we can see there are 4 different group of viruses, those been circulating in Pakistan. And one of my students is really looking very deeply into those sequences. We didn't find any signature or any mutation in Pakistani isolates that can make the virus more weaker or less transmissible. But I think one of the factors that has been very commonly observed now is that most of the people who were already very vulnerable to the infection, either they are succumb or they got the immunity against. So the new patients, those are coming in, they might be having the virus, but they are less likely to succumb to the infection or show very severe situation of the coronavirus. But also, over the time, we have learned enough what kind of treatments are working, what kind of capabilities are required, intensive care is needed. So based on our previous experiences, overall mortality is decreasing and leveling off. But I don't really buy the idea that the virus is getting weaker in Pakistan.
Right now, a college London study stated that there is a way to identify which strain is existing by looking at the symptoms of the virus. How much more can we understand from this study? Do you think it's credible enough to give lend more understanding to the fact of how we can distinguish these strains?
Yes, absolutely. I think one thing I would like to clarify here is that although there are 7 different clades, some of the clades are very predominant, for example, G, GH, and GR. But there isn't any particular signature that we can identify that this mutation is making it more transmissible or not. We have 20 different mutations that have been recorded so far, except one mutation, which is D614G mutation that is in one of the spike protein, the one that is on the surface of the virus. That is something being associated that if the virus has D, it is less infectious compared to if the virus has G. These are the genetic coding at 614 position. But that study has mainly been conducted in vitro in the cell culture in the laboratory. But the real implication of that mutation 614G in the actual field condition is really weak, and we don't really have strong evidences that that single mutation is going to make any virus more critical for the transmission. But also, this mutation particularly is lying somewhere very close to the epitope that is not important for the vaccine efficacy. So therefore, there isn't any particular mutation identified so far that can identify that this is more severe version of the virus or can say that this is more transmissible version.
Right. I take your point there. Dr. Fawad Muhammad, you mentioned a point earlier which was talking about which strain existed in Wuhan and then it was phased out for another one to come in. What really causes this phasing out, as we're talking about, of strains and the virus changing from one to the other?
It's depend on the virus behavior, which kind of the virus is get more compatibility to the host. So this is a kind of behavior naturally occurring in the virus, and it's also depend on the compatibility of the virus with the host. So initially the S was more predominant, but as with respect to time, the L clade get more compatibility and it's become more prominent. So I think it's depend on the virus behavior itself, and also depend on the on certain environmental factors as well.
What environmental factors would you say do contribute to this change?
I think, in my opinion, if we could look at the weather here in Pakistan, so it's almost a monsoon here. So there is more humidity here. So I think this factor can also contribute somehow to the virus infectivity.
All right, I'm going to take that point to Dr. Muhammad Munir, and I want to dig a little deeper into that because Dr. Munir, earlier on, was reiterated again and again by the World Health Organization that weather, climate does not impact the virus. Is that changing?
Well, Michelle, the point is that we don't really have a backlog history of this disease. It's still new. It hasn't passed through the whole year. So therefore, it would be very immature to really look into whether the environment would have any impact. But I think one thing is clear, that with the coming fall and early winter, we will be having influenza, we will be having rhinoviruses and other infections of the respiratory tract. So even if this infectivity for the SARS-2 itself would be reduced, then we will have a burden of other infections. So all in all, I can't really see any positive impact of changing weather onto the transmissibility of this infection, unless any luck comes up, and then we will have some mutation in the virus that it would reduce its transmission. But as it stands, I don't see any changing of the weather would have any impact onto the virus transmission. And as we have seen that during this 7 months, the disease has been in different part of the world where the temperature has been different. For example, in Kenya versus in Sweden, so the temperature has already been very variable, and we didn't see any difference of the environment onto this virus, unfortunately.
Right. Now, one thing that we saw a lot of in terms of visuals coming about were these mutation maps, colored maps that indicated which virus strain is going where. It really helped with trying to track down and trace where the virus was originating from. How does that work in the case of travel? How helpful are those types of exercises? And when we talk about specifically regions having different kinds of viruses, how much difference is there?
Yes, absolutely. I mean, as I mentioned, there are 7 different clades, and those clades are predominantly everywhere. And these mutations that we have identified in the beginning, for example, the D614 from Wuhan down to 614G into Europe, and primarily those were predominantly identified in Germany in early days, in January, basically. So those mutations, once identified, then we can trace them down where these went into, and most of the Americans isolates, they came from Europe. So if we really look onto the global perspective as we stand now, G, GH, and GR, these are the 3 different clades. Those are predominantly around the world. There isn't any single cluster that we can say that this is predominantly in this country and this one is in another country. However, V, O, and L clades, those were first isolated from Wuhan. Those are reducing in number. I think that is just because the control measures that have been put in place in such a way that the virus didn't get a chance to escape any further. So therefore, all in all, there isn't any particular virus that is predominantly spreading around the world. It's all clades, those are around the world.
Right. Dr. Muhammad, when we were talking about the case of Pakistan and talking about whether or not the virus here is mutating, Dr. Muhammad Munir stated that he doubts that there's a mutation taking place, but we are seeing less and less cases, probably because of less testing. What needs to be done in order to strengthen the tracing and tracking process of trying to contain this virus?
We should keep the diagnosis on the priority because recently we are again seeing there is a increasing the number of cases again, and we also need strong epidemiological studies to really understand the virus behavior, because as earlier I mentioned that this virus is totally peculiar and the behavior is also very peculiar. So I think we will understand this virus with respect to time. So I think we should keep our diagnosis on priority and to better understand the cases scenario in Pakistan. And alongside, we also need some strong research to really understand the epidemiology of the virus and the behavior of the virus.
Right. Dr. Muhammad Munir, running short on time, but I do want to put this one last question in because it is a big update, especially coming in right now. The Russian vaccine showing a lot of promise and it being the first to enter the market. We're hearing a lot of news and buzz about it. How promising does that seem?
Well, Meshal, I covered this one since morning a couple of times. Well, the thing is that the technology for the Russian vaccine is not new. It's same technology as the Oxford University vaccine adenovirus. And they have demonstrated this efficacy against Ebola virus in 2016. So therefore, they were able to really repurpose it to develop a vaccine for coronavirus. The technology is proven. However, there are certain questions the way it has been tested in phase 1 and phase 2 trials. And phase 3 trial is still ongoing, so they have approval process before the phase 3 trial is completed. So therefore, we don't have access to the original data on any of the trial on the safety and efficacy. Therefore, it is really difficult to preclude what is really they are counting on and for the approval and registration process. But that is something really to look positive on as long as it is distributed within Russia, because they have been doing all the trials within the country.
Right, I take your point. There is a question mark on the safety and efficacy of this vaccine that has been declared as the first one to enter the market. Thank you so much, Dr. Muhammad Munir, for joining us, Dr. Fawad Muhammad for joining us from Peshawar. We're going to go for a short break, but when we come back, we discuss accounts being given by people who say they have been experiencing COVID symptoms for months, and that's without having been hospitalized. Stay with us. Welcome back to the show. There seems to be a less discussed type of COVID-19 experience, one that lasts for months. Individuals experiencing this are referring to it as long COVID or the long haul. Let's discuss this further. Joining us for this discussion is Professor Derya Unutmaz, who's a professor of immunology at the Jackson Laboratory at Farmington. He joins us from Farmington. Also joining us today is Dr. Syra Madad, who's an epidemiologist in public health and special pathogens preparedness and response. She is a senior director at System-Wide Special Pathogens Program at New York City Health. She joins us from New York. Thank you both for joining us and welcome to the show. Professor Unutmaz, let's jump right into it and talk about what people are referring to as long COVID. Now, before we dig deeper into what this experience is like, how do we distinguish long COVID from what are the more normal cases of coronavirus that people who are at home don't have to be hospitalized experience?
Sure. So what happens is that, people who are treated, who are usually sick in the hospital and the virus is gone and they're, sent home in the recovery phase. Of course, there's always a few weeks of recovery. This is a very severe disease. But what happens is that, after months, in some cases, the symptoms sort of flare up. Some of these patients are feeling very tired, headache, muscle pain. There's some people are experiencing rashes and a variety of symptoms that are showing up. And it doesn't appear like they've been reinfected. I mean, they cannot detect any virus in these people. And so it's sort of the symptoms linger on. But maybe more importantly, there are also some psychological or maybe biological neurocognitive symptoms. Many of these patients feel a sense of depression, anxiety, loss of smell continues at some point. And we know that the virus actually affects the brain and many organs. This is a system-wide syndrome. The number of patients have heart defects. Those that have been hospitalized, up to 60% of them show a certain level of heart problems. And again, we know the virus can infect heart cells. Probably there are some issues in the lungs that remain. So it's unclear what's going on. But then lastly, one of the issues could be the immune system. And we know that this actually happens in another condition, which we actually study, called chronic fatigue syndrome. And this is a condition that can last for years. These people, usually very healthy people, they have some sort of a viral infection, it could be flu or something else, and then they never recover. So it almost feels like their immune system have fallen off the cliff and is unable to get back to its normal steady state. So that could be a potential worrisome situation for future as well.
Right. I take your points there, and it's important to discuss exactly who's getting impacted by this, given the anecdotal accounts that we're hearing and the different news coming in. But before that, I want to jump to Dr. Syra Madad and talk to her about this tweet that basically encapsulates the experiences of people who have long COVID. I'll read out this tweet for you. I think the medical profession needs a new word to say to people with long COVID. COVID, when they describe their symptoms going on for weeks, months, it would mean, I believe you, I witness your suffering, I share my uncertainty with you, I can't cure you, but I will not abandon you. Now, these sentiments of not being believed for having long COVID is something that we're hearing again and again from people. Why do you think there's so much difficulty in recognizing this as being a part of the COVID experience?
Well, this is a new virus, and so we're learning a lot about the disease every single day. And so I think that individuals that are not versed in virology, that are not versed in infectious disease, have a hard time grappling with the fact that some of these diseases do have long-term sequelae. So there is a term for it, and we don't know a whole lot about sequelae. And what this means is that there will be a subset or a fraction of the population that does get infected that will have long-term effects because of COVID-19 infection. This could mean it could be affecting the heart system, it could be the kidneys, it could be the brain. We know that this is not just a respiratory infection, it is a multi-system infection. Some individuals will have a much longer time in terms of recovery. If you look at individuals that have mild cases, usually the recovery period is about 2 weeks. Those that have a more severe case, they can go on for anywhere from 3 to 6 weeks plus. So there's a lot we don't know about COVID-19, especially when we talk about the long-term effects. And we are learning a lot. I think one of the things to also mention is if you look at the family of coronaviruses, if you look at some of the sister viruses like MERS and SARS, and those that have recovered, they have had similar instances that where those individuals had long-term effects from their infection with the family and coronavirus. So this is not something new, but obviously this is a new virus that we're dealing with, and so it's going to take time for us to learn the full burden of illness, the full spectrum of illness, if you will, that is being caused by COVID-19. So I would just tell obviously public health officials and those that are obviously in this field, and we're very well aware of it, is that it's just something that time will tell how the disease will affect, overall in terms of the human population over the next months to years.
Right. Now, you mentioned here how it's not just a respiratory disease, it has many other side effects. And I do want to talk about that narrative a little more. Now that we're finding out things like this, how individuals later on can continuously have depression, anxiety, something that can be very much related to the illness, not just a later on side effect of it. Do you think we need to rework this narrative internationally about it just being focused on the respiratory system?
I do think so, and there is information out there now. I mean, if you're looking at the medical literature, it's very explicit that COVID-19 is not just a respiratory disease. It's showing that you have effects on all the different organ systems within the human body, and we're learning a lot about this every single day. There's been a new publication in JAMA just last week about this. In particular, it was talking about the risk, the higher risk of stroke, and you're seeing an uptick of stroke for those that have been affected with COVID-19 infection. So we are, we are acknowledging the fact that this is something that is not just confined to the respiratory system, but in terms of obviously getting the full picture of the full burden of illness, this is something that obviously is still being investigated. I think for myself on a personal level, I had COVID-19 in March. I had lost my sense of taste and smell for almost a month and a half. And given that this was a new virus, obviously it was something that was a bit scary because you didn't know if I was going to get my sense of smell and taste back. And so I had a long-term, symptom that lasted for quite a few weeks. Even though I had a mild case, my symptoms lingered on for quite a bit of time. And I know there's a lot of individuals that are in the same boat as me.
Right. And Syra Madad, I want to come back to your experience and other experiences. Before that, I want to go to Professor Derya Unutmaz and talk to him about the people who are getting impacted by this. They seem to be younger individuals, healthy individuals with no underlying conditions. What really causes for this case to become more severe in some individuals and mild in other ones? Do we know more about this?
Yeah, that's a very important question. But before that, I just want to add a very small thing to your previous question, because I think that's very, very important. As Dr. Madad mentioned, there's a variety of symptoms, and this is a very traumatic experience. So the fear is that, and we've seen this with chronic fatigue syndrome, that some of these people might have a certain stigma because symptoms can be very vague. confusion, depression, pain, and things of that nature. So it might be confused between psychological effects and actually biological. We think it's really a biological effect. And so I think this is going to be a very important issue to educate the public. Regarding your question, that's a very, very critical question that we still don't have an answer to. It's actually not just the young versus old. I mean, there are cases where very old people have a symptomatic infection or very mild infection. And there are cases where young people have very severe infection, although it's overwhelmingly over the age of 50 who get the severe disease and mortality. Children, it's a very, very mild condition, which is also very puzzling. In fact, if you look at the statistics in the U.S., the number of children, I think there are about 350,000 documented cases of children. Only about 84 of them have died. That's actually twice less than children died from flu infection this year. So for children, it's even comparable to influenza. Whereas as you get older, it becomes a very, very high mortality risk. What are the reasons? We know that it really associates with certain factors. For example, diabetes, hypertension, obesity, and age. So a number of things could be happening that could potentially explain this difference. Number one, the virus has to get into the cells in order to replicate. And in order to get into the cell, it has to bind to this receptor called ACE2. It's like a lock that the virus has to open in. So there's some evidence that, for example, very young children under the age of 5 have very low levels of this ACE2. So one of the reasons could be that the virus is not able to set a foothold in deeper tissues because of that. Whereas it could be increased in cases of hypertension. Of course, there's the big influence of the immune system, whether certain people who have diabetes and other comorbidities and during age, that their immune system is not capable of coping with this virus. In fact, it's the immune system that sometimes kills these people. Right. In the late stages, you use an immune suppressor. So it's a really open question. I mean, men, for example, have two times higher risk of dying from COVID. We don't know. For example, estrogen, women's hormones, could have a beneficial effect. There are some reports about that. So I think there's a combination of genetics, environmental factors, and the comorbidities, the chronic diseases that somehow makes this condition. And it's very puzzling. We haven't really figured it out yet.
Right, and if you haven't figured it out, it's us even more confused. People who don't know what's happening at the back end of this are confused, are scared of what's happening. But to that very point of how experiences vary and how so many other factors need to be taken into account, I want to take this question to Dr. Syra Madad. And Dr. Madad, as you mentioned, your experience was puzzling for you and you're an expert. Now, from a research point of view, when dealing with a new virus like this, how important are anecdotal accounts? How important are experiences, individual experiences that people tell? How much are those factored in when trying to create policies and deal with what's happening?
So it's all about the personal experience, because that's how we learn about the virus. This is how we know what's actually happening in the human body. So it's not just about those that have been hospitalized. A lot of research obviously is done on those that are hospitalized because it's a controlled environment and we know that they're in a state of illness. Less so, obviously, those that are maybe having mild illnesses and don't warrant, seeking healthcare services. And this is where it's important to hear stories of these individuals that are not, being hospitalized. And we are hearing a lot of these experiences. I'm one of them. I know a number of colleagues are in the same boat as mine, same boat as me. And so we are constantly sharing our experiences. And this is also why the CDC, for example, a few months ago updated its list of signs and symptoms of COVID-19, including loss of taste, of smell, an additional 3 to 4 additional symptoms based on hearing what people were actually experiencing, and then updating those types of clinical manifestations. And it's important because this is how we learn. I think it's also important to note that people often expect, to learn or know everything about a given disease or a given virus in a very short period of time. And if you look at history, if you look at just to say Ebola virus disease or Nipah, these are viruses that have been around for decades. And we are still learning about these viruses. We're still learning about a number of these microbes, even if they are decades or centuries old. And so a virus that, for example, with COVID-19, that is only about 7 to 8 months old, the amount of information that we've learned in this very short period of time is really unprecedented. And the reason for that is because this is obviously a global community coming together and trying to learn and sift through the information as fast as possible. But there's only so much we can learn in a given time period, because what we know about infections that you need to look at the long-term effect, and long-term means over time. And so there's a lot that we're going to find out over time. Another good example is Zika, right? So a few years ago, we had a Zika pandemic all around the world. You still have children that were born with microcephaly that we're still following and figuring out what are the long-term consequences of them being infected with Zika. But we won't know the full picture until another few decades. And so It will take time for us to get the full picture.
Right. I get your point there that it's to require a lot of more information coming in, a lot of more analyses, a lot of more research for there to be, for the missing pieces of the puzzle to be found. But Dr. Syra Madad, when we talk about long COVID especially, and we talk about people who have to sit at home for very long duration, experiencing extreme symptoms, even if they don't need to be hospitalized, we know that this condition is being recognized more and more across the world. What type of healthcare support should be extended to these people?
That's an excellent question. And the reason why I said it is because, at least in New York City, in the healthcare system that I work in, so I work in one of the largest healthcare systems in the United States, and we've put together what we call a take care package. So even if you can't go to a hospital because you warrant that level of care and you're going to be staying home, we're actually providing them a bundle of different supplies. And these supplies include, for example, a pulse oximeter that measures the oxygen level in your blood, right? We also are providing additional supplies and equipment like thermometers to check your temperature. You have people calling you. If we know you have COVID-19, if your laboratory confirmed, we have a huge contact tracing workforce where they call you twice a day to check up on your signs and symptoms. So we have these processes here, at least in the United States, and I can only speak for New York because I'm part of the response here. And obviously, every state is very different in how they're responding to COVID-19. But those are some of the resources that we are putting into people that are trying to safely isolate or quarantine at home. On top of that, what we also have are isolation and quarantine hotels, because what we know is not everybody can safely isolate themselves at home, because a lot of people live with 10 other people in their home and they live in a 2-bedroom apartment. So trying to maintain that physical distancing is extremely hard. And so we have isolation and quarantine hotels free of charge, free meals, free health checks, where they can go in for the duration of their illness.
Right. Dr. Syra Madad, running very short on time, but I just want to put one small question to you and one last question to Professor Unutmaz. I'll take it to you first. I know this is a big question, but if we had to summarize it quickly. Now, when we talk about not knowing nearly as much as we would like to about this virus, how do we make reopening strategies? How do we work for those?
Well, we do know some information in terms of COVID-19. And what I'll say very quickly is what we know based on the information, the data that we have. Everything needs to be based on science. Everything needs to be based on evidence. It can't be anecdotal. It can't be, well, children, may not have COVID-19 or may not transmit the virus. That's not true. We have information on that. And so we have to be very methodical in how we're approaching this. And so we know that ventilation is key. We know that being in close contact with individuals is obviously another factor. We know you want to make sure you're doing these everyday measures like wearing a mask, things like that. And so we want to make sure any policy, any recommendations, anything that we're doing in terms of reopening up schools or businesses is based on science and public health information and the best information that we have at the moment. We know things will change because this is a new virus and things need to change as we learn more, but we need to go with what we know right now that's based on science and evidence.
Right. Professor, one last question to you. Now, when we've been talking about long COVID, we've been talking about different things that happen with different people, the different variances. Now, one narrative that has been very prevalent, at least in Pakistan, as cases have fallen, is early intervention, and that includes early intervention with antibiotics and medicines to tackle these various symptoms. You as an expert, how much do you agree with that early intervention by giving antibiotics and other medicines to try to contain the spread of the virus within the human body? How much do we know about that?
So antibiotics do not have any effect on viruses. They are usually used for bacteria. So the only reason you would give antibiotic is to prevent what we call secondary infection. So if you have coronavirus infection and on top of it you get another bacterial infection, you use antibiotic. Other than that, there are really no evidence for anything so far that if you give it early on, that will prevent the disease. There's a lot of trials going on. In particular, what I'm excited about is the antibodies that are specific to this virus. The clinical trials just started in NIH, and so these will actually stop the virus early on. And so I think they could even be used as a prophylactic, so you can give it to healthcare personnel, and that could actually replace a vaccine for a while. Because it will prevent the virus from getting. And there are other type of drugs that are being used, such as interferons and things of that nature, that could be given. But these are all in randomized placebo clinical trials. So at the moment, unfortunately, we really don't have anything that we can say, take this and you won't get sick.
Right, I take your point there. Thank you so much, Professor Derya Unutmaz, for joining us. Thank you so much, Dr. Syra Madad, for joining us and taking out the time. Thank you for watching Indus Special. We will see you again tomorrow with more stories. Till then, goodbye and take care.